Classification of cyanotic CHD. 1. Left to RT shunt ASD, VSD, PDA. 2. Obstructive lesion coarctation of aorta. Types of VSD. 1. Outlet subarterial VSD. 2. Paramembranous VSD. 3. Muscular VSD. 4. Inlet VSD. Which type of VSD never close spontaneously? Inlet VSD. And also there is increased risk of mitral valve defect. Which type of VSD most commonly close spontaneously? Muscular VSD. Most common type of VSD. Paramembranous VSD. Its defect in upper membranous part of interventricular septum. Outlet subarterial VSD accompany which herat defect. Aortic defect, aortic regurgitation. Pathophysiology in VSD. 1. PSN systolic murmur at fourth intercostal spaced septum. 2. Cause blood from LV comes to RV so more blood flow in pulmonary arteries so ejection systolic murmur. 3. More blood flow across mitral valve so delayed diastolic murmur at mitral area. X-ray finding in VSD. Cardiomegaly, apex pushed outwards. CT ratio increased. CT ratio formula and normal value. CT ratio equals A plus beat C. Children less than 0.55. Infant less than 0.6. Complications of VSD. Early complications. 1. Recurrent pneumonia. 2. CCF. 3. Risk of infective endocarditis. Late complications Eisenmenger syndrome. Eisenmenger syndrome. Eisenmenger syndrome is a condition arising from VSD, leading to pulmonary hypertension and a reversal of blood flow, causing oxygen-poor blood to enter the systemic circulation, resulting in cyanosis and other complications. Indication for surgery in VSD. 1. If CCF is there after supportive management. 2. QP, QS greater than 2, 1. 3. Associations valve defect, AR. Types of atrial septal defect. 1. Ostium secundum ASD. 2. Ostium primum ASD. 3. Sinus venosus ASD, SVC type. 4. Sinus venosus ASD, IVC type. Which ASD type is associated with conduction defect? Ostium primum ASD. Most common type of ASD. Ostium secundum. Pathophysiology in ASD. More blood in RV. Delayed closure of pulmonary valve. Delayed P2. Wide splitting of S2 diagnostic. ECG finding in ASD. In ostium secundum, right axis deviation. In ostium primum, left axis deviation. Indication for surgical closure of ASD. If ASD persist for 3 to 5 YRS. If side greater than 8 mm. PDA is associated with which torch infection? Congenital rubella. Murmur location and characteristic in PDA. Loud continuous machine-like shunt murmur. At peristernal area of second left ICS. Complications of PDA. 1. Recurrent pneumonia. 2. CCF. 3. Eisenmenger syndrome, cyanosis only in lower limb, upper limb spared. Medical drug for PDA. NSAIDs decrease prostaglandins production, PDA closure happen. Ibuprofen greater than indomethacin. Most common location for coarctation of aorta. Juxtaductal near ductus arteriosus. Clinical features in coarctation of aorta. 1. Shock in neonates if near complete obstruction but it's rare. 2. Due to decreased blood flow to lower limb so. Claudiction pain, feeble femoral pulse, radiofemoral delay. 3. Decreased blood to kidneys so hypertension. Compensatory changes in coarctation of aorta. Seen in older children's. 1. Formation of collaterals so blood diverted to intercostal arteries causing inferior rib notching. 2. Free sign on X-ray dilatation in aorta.